Hello, and welcome back to the Compassion in Therapy Summit. I'm Ravi Chandra, a psychiatrist, author, compassion educator, and filmmaker in San Francisco, California, and you can find all the links in my bio. I'm delighted to be your host once again. In this session, I'm happy to be speaking with Dr. Russell Razzaque to explore open dialogue, an exciting, rapidly growing, evidence-based, compassionate, and holistic approach to treating intense mental health crises, including acute psychosis and schizophrenia. Dr. Razzaque is a psychiatrist based in London, UK. He is a mindfulness teacher and also open dialogue trainer, recently publishing a key book in this area, Dialogical Psychiatry. He is also a visiting professor at London South Bank University and has published extensively on relational ways of working like open dialogue. He is currently leading the world's largest open dialogue trial. Thank you for being with us, Dr. Razzaque. Thank you. And in this moment, I am touched by the experiences of all the people I've known who have been affected by severe mental illness and all those who have been harmed by medical systems. I'm especially thinking of people in the US shot by police, 25 to 50% of whom have mental health issues. I'm so filled with hope that your work can make a big difference in the lives of many in changing systems of care and understandings of mental illness throughout society. So let's get right into it. What is the open dialogue model for those who have not heard of it?
Sure. So I guess open dialogue is different to the normal way we kind of deliver care in mental health systems, in that in several different ways. The first thing is that we're always thinking about people's own resources, their family and their network and the people around them, and how they can all participate as active partners in the process of care. So we then teach staff to work with this group in a less hierarchical way, so that it's not so much that we're the experts, the psychiatrist and the nurse and the social worker, we're the experts and they kind of follow our tune. It's more a case of us collaborating together on a lot more of an equal footing, where we can learn from everybody else's understanding of what's going on. So the skills that we teach staff to develop in this kind of context involve being able to create a safe space where people can start to open up about their journeys, develop their own narratives and understandings of what's happened, and we learn from them. So, in the early days, I might say somebody, if I get, well, you're the doctor, you tell us what's wrong, what's the diagnosis and treatment, we'll tend to say, well, in many respects, I certainly haven't had your experience, and in many respects, you're the expert in your experience, and you as a family or a group of people have been through it together, perhaps we can learn from you. And so we reset the dynamic that way. We try to create this safe space. We use a series of techniques to work systemically, create a safe space where people can start to open up. We want to have as many voices as possible. We're not looking for a consensus. We're just looking for people to be able to open up what's their own truth and their own understanding. And that way we then work with them. We're then guided by them and led by them in terms of the process that goes forward. Professionals are still involved and they still have their expertise, but we keep that in our back pocket and we bring that out if it's needed, whether it's medication or other things, but we don't start with that. We don't push for those things, and we very much are guided by the family network. And we want to empower them. The main thing is to give them a sense of agency from day one. And we think that's fundamental in people's healing journey, cultivating that sense of agency, a sense of own control, and also having that space where they can actually open up to speak things that they may never have spoken before, right? Speak of things that perhaps they haven't done to each other. So it's very much about that. We also have people with lived experience in our teams to make sure that it's a way of the team grounding itself in respectful lived experience, understanding that there's something that you can really develop and grow as a result of that. And so we have lived experience workers working alongside the psychiatrists and others in the team. It's quite a different culture, if you like. It also involves some training, and it involves a lot of personal development on the part of the staff. So we have staff doing regular work like their own genograms and family of origin work, working in pairs to understand their own trigger points and doing some work on ourselves, which is fundamental. Also, I teach open dialogue to staff, meditation staff, mindfulness, to help them understand, reconnect sort of deeper levels of themselves, all of this, I think, is really important in order to be able to work this way, because it is it can involve bringing more emotions and things into the room. But if we're able to do that with ourselves, then we'll be better able to do that with the people around us, and we'll also be better able to allow people to have the experience rather than reflexively trying to remove it, which is what often systems do. So it's very much about honoring that experience, enabling people to have it, stepping in, intervening if needed, because if it's too powerful, if there's too much that people need some help with, but otherwise enabling people to have that experience and often transform through it. So that's in a nutshell really what open dialogue is kind of about.
Thank you. So I hear listening, understanding, relating across the whole social and therapeutic network is really key. That's wonderful. And you also mentioned mindfulness. So where does this concept of open dialogue come from? What are its roots? And how might it differ from treatment as usual? And particularly, I think my understanding is your contribution is the mindfulness training of practitioners, a particular aspect of your contribution. So maybe you could talk about that.
So open dialogue itself as a kind of mode of care developed in northern Finland back in the 80s. So they've been doing this for some time now. And they originally had some of the worst outcomes in the world, actually. And so what they decided to do was to shut down lots of their services and open up a series of experiments, one of which was called Open Dialogue. And what that involved really was, as I say, training all the staff in working systemically, creating these safe spaces, using these techniques to work in a less hierarchical, more collaborative way. They found the outcomes were radically different. They found that people after a year or two in their system were leaving the service for good and not remaining long term. The number of people who had long-term mental health problems was way less than anywhere else. Now, while we'd heard about this, nobody, and there's pockets of it in different parts of the world, nobody had taken it up on a mass national or even regional basis anywhere. And the reason is that their experience there, they hadn't done anything randomized. So it was basically their own local community that they'd worked this way and they'd seen the differences themselves. But what policymakers want is randomized trials. They want to show that it wasn't something like the change of weather or water that affected the difference. They want to show it actually happening in a randomized way. So we developed a training locally in the UK with the help of the Finns. We got them across. We flew them over several times a year to deliver training to our staff. We've now got our own training, that we've taken over ourselves, which very much after years of work with the Finns have managed to do. And as you say, mindfulness is a part of that training. We believe that clinicians are very much more able to work this way if they're more in touch with themselves and they're able to sort of be present with what's going on for themselves. That will enable them to be more present with what's happening in the network. It's really about being connected to that conversation and being guided by it rather than feeling the need to control it. And that's a key part of it. Interestingly, the Finns never thought about mindfulness as a part of this and how to train people in it. But after I've been working with them for years, wrote some papers on it, they realized actually, yes, this is a lot of what we're talking about. And they realized that actually, that embodied connection that we talk about in open dialogue, we have clinicians working in pairs and reflecting with each other in front of the family about their own feelings, their own physical response to what they're hearing. And a lot of that is very much in the language of mindfulness too. So it seemed to make sense, and now in a number of open dialogue trainings around the world, they're also using mindfulness as part of it. And the way I guess I think about it in an overall sense is that these are things kind of deeply ingrained in the human psyche anyway. We know these things. It's a kind of ancient wisdom. There are native cultures in lots of parts of the world, whether it's in America or Australia or the Indian subcontinent, where these kind of meetings, these kind of gatherings have always been the case, right? When there's been major breakdowns in communication, in relationships, in people's own mental health, they've tended to start by coming together as a group. I was teaching a group of people last week in London, and there was a few people who family background in Africa, and they were talking about how actually this makes a lot of sense when we think about the African culture, where in their own cultures where they're from, the chief would have brought a lot of people together into a room where they really talk something through, as opposed to going straight into labeling it and then going to sort of down a clinical route. So I think that this has always been around. It's been around in ancient times, and then the emphasis on being present, on people actually having their experience rather than running away from it or trying to remove it, has also been around, in terms of ancient wisdom. So I think it's sort of bubbled up in different guises around the world. And in terms of the kind of professional, if you like, clinical arena, it's the Finns who first sort of injected a lot of that into there. Although there are other things like mindfulness-related therapies that have been coming about for some years now, whether it's transpersonal or compassion-focused therapy or acceptance and commitment therapy. So a lot of these things I think are bubbling back up, but we have to remind ourselves that none of this is really that new. The research is new, but the actual origins of it are quite ancient.
Yes, thank you. Actually, that reminds me that strikingly, outcomes for severe mental illness in developing countries are better than so-called developed countries. Rates of and also rates of psychotic breaks in immigrants are 3 to 5-fold higher than the general population, immigrants to the Western world. So, that brings up the question: is something missing in our social fabric that open dialogue is helping to restore?
Yeah, you mentioned those early papers, which are absolutely fascinating because they were done by the WHO, weren't they? They go all the way back to the 1960s. They did a very large trial across 8 countries. Then I think it's 6 or 8 countries. Then they repeated it again in the 2010s. It was about 1990s, and they found exactly the same data. Then they did a 10-year follow-up in the 2010s across about 5,000 subjects, and they found the same thing in developing countries who have better outcomes for severe mental illness than they do in the West. And that's a major thing that needs to be answered. I think part of it is very much about those cultural approaches that involve actually helping people to understand it in the context of their own understanding, their own culture, their own narrative, which makes a lot more sense to them. It helps them find a way of healing, rather than going straight into sort of pathologizing and starting to get active clinically. And there's a role for all of those things, right? There's a role for all. There's also some aspects of Western medicine that can help there, but vice versa. So we're kind of learning from each other, and it's a process where there's a great deal of value in the exchange. So yeah, it's as you say, that's been something that's been around in all of these cultures, yeah, I think it's just been very interesting to see this trajectory, in which people are beginning to learn some of these things that have been around for a while, and beginning to find that it really helps them as well. So the clinicians find that learning this way of working, training in this way of working really helps them in their own lives, with themselves, with their families, and it seems to have quite a substantial impact, which is why they also develop this very strong affinity for this way of working. And there's a lot better staff retention in these services actually than in other services. That's kind of my experience. So I can't remember if I mixed off the end of what you asked there.
Yeah, do you, just to speculate, do you feel like this shows that there's something missing in the social fabric of Western countries that is being restored by open dialogue?
Yeah, I guess the big obvious difference is that in the developing world, people live in extended families more, either in or around their extended family a lot more. So they're all, like my grandma's family in Bangladesh, they pretty much all lived on the same couple of streets. They're all very close to each other, so they could come together. Whereas, in the West, families are more atomized, and I think it is very much about the power of community and social network. And actually, often affluence can lead to separation of people. So I think in more affluent West, we have been separated from each other more. And actually, in open dialogue, what we're finding is that the crisis is an opportunity to bring people together again, to knit that fabric together again. And very interestingly, the pandemic enabled us to do something that we hadn't formally done as much, which is that prior to the pandemic, we were inviting anybody around to come. So you'd have the client, then you'd have their family members who live near them. Maybe they might come, or friends or colleagues. And that might be a couple of people, there might be more people, there might be no people, right? It just depends on who they have. But in the pandemic, we were forced to work virtually. And there actually, suddenly, there was a whole layer of relatives who are all around the world, and they could join the meeting. So we started to do open dialogue meetings online. That enabled us to broaden it out, actually, and really bring that community together. We'd have some meetings face-to-face whenever we could. And after the first wave, we did, but we then carried on online, bringing wider meetings together whenever possible. So I think that is something that we've been able to do, and it is in some respects a bit of a copying of more of the structure that you have in developing countries around that community base. And I think that really helps. And whenever there are initiatives to do this, bringing communities together, I think it really is fundamentally what we need in the human condition. I think what we're lacking at the moment is that community spirit often, and even in our wider power structures, the way our democracy works, it's very much still individual. You elect one person, to take decisions for everybody else, which I don't think is really tenable very much. Or having groups of people make decisions together for everybody else, that works better. And I think a lot of the problems we're seeing politically are actually lack of that. So I think that community resource, that using the resource of the community, bringing the community together, working less hierarchically as part of a community, I think all of those things are things we're all learning, whether it's in the healthcare field or further beyond. And I think all of those things, there's a lot to build on in each of those areas.
So is open dialogue primarily for psychosis, or is it a transdiagnostic treatment model?
Yeah, good question. It's very much transdiagnostic treatment model. So across the board, people will be, whoever comes into our services will have open dialogue. And for those people for whom it's less severe, their need is less acute, then they might just have one or two, open dialogue style meetings. For those people who have a more severe need, they may have many meetings. It may stretch on for years. There may be very regular meetings at the beginning and less frequent later on. So it's very much, something that we work on over time together. But there's no one who's really not appropriate for open dialogue. We don't say it's only for these people and this sort of sector of folks with this diagnosis. It's absolutely for everybody. People often make the mistake in thinking open dialogue is for psychosis, mainly because Jaakko Sekula, who did the original research in open dialogue, mainly published the data for folks who had psychosis. That was most stark. But that doesn't mean that the service only looked at folks. They looked at everybody. So it's ended up sometimes people thinking this is psychosis, but it's not actually. It's definitely across the board. Yeah.
Yes, thank you. So practitioners have been advocating for system-level collaborative care for conditions as varied as somatic disorders to psychosis and addiction. And this has generally been to get all the caregivers on the same page with each other and the patient. And research, for example, has shown that addiction emerges universally as a biopsychosocial response to the disruption of normal social interactions. So can open dialogue, is it working by, again, enhancing those relational understandings and experiences? What would you say are the putative mechanisms of action of open dialogue?
So I guess there's a couple of ways of thinking about this. One of them is that I think certainly one part of it, there's probably several layers to it. One part of it is that people get a sense of control and agency in open dialogue meetings because it's less hierarchical, because it's not about the professional telling you what's wrong, what to do. You don't need them as much. You realize that you're using your own resources and you have it within you to make that recovery journey. So I think that's key. Just that enabling people to get that sense of control and agency themselves. I think that's key to it. Another key is of course the bringing together of the social network, the size and strength of the social network. How early on in the treatment we kind of do a network map with service users. We say, look, let's think about who else is important to you in your life. Who else could you bring, and who else is part of your community? And we help them form a community if they don't have one as well. So that's also key, part of the mechanism of change. I also think at a deeper, more psychological level, if you're with a group of people, loved ones who you know, and you're hearing not just your own story, but you're hearing their story too. You're also hearing about their reactions to some of the thoughts you might have. We want to create as safe a space as possible. So people might start bringing up thoughts about how they feel towards themselves, which might be quite negative. And then to hear the response to that from your loved ones. Well, I haven't heard you say that before. And to be honest, my feeling is ... And the feeling is often one of affirmation when actually, you don't realize how much you mean to me and how much you mean to us and things like this. And so creating a space in which that dialogue can happen really makes a big difference. So I think that, so there's several levels. There's the level of sort of agency and that kind of personal ability, that sense of using your own resource. There's the level of the social network, just being there and being present and being larger and deeper. But also there's a deeper psychological level in terms of people, a lot of thoughts that have been festering away internally for years. We hopefully will have succeeded in creating a space where that can actually come out, and that having seen the light of day, its nature will change because people will realize actually if I voice this, the people who love me are saying something else about their experience and their understanding, and perhaps things aren't as bad as I think. So I think there's something about opening up and getting that feedback. There's also something about just the existence of that network. And then the third thing, as I say, is about that sort of control, that sense of agency you have over your own care. So I think there's a few things, and we're exploring each of these actually in little mini studies, looking at the people who are having it and examining those as well.
Fantastic. So maybe you could describe a little bit where you are in terms of this research trial. It's a very large one.
Yeah. Sure. Yeah, it's also the biggest sort of model of mental health care, which is a whole model of mental health care change in the world at the moment. And the thing about open dialogue is it's not just a therapeutic modality. It's not just a therapy or an intervention. It's also a model of service design. So you can do dialogical work anywhere, but to do full open dialogue, you also need to have a service organized in the right way. Now, what that means is that we need certain things. So as well as what I've described in terms of how the clinician works, we also need to make sure that there's continuity across the care pathway. So whoever starts working with them at the beginning continues to work with them across the care pathway for the whole time they're in the system. So they're not being passed from one team to another team, which happens a lot in standard services in the UK, and going to different professionals. That's not conducive to forming these long-term, deep relationships. But that's also key, a key operational requirement. We also need to make sure that the similar staff who are involved all the way through. We need to make sure that we have a couple of clinicians in each of these network meetings. Not every meeting needs to be a network meeting. You can have one-to-ones too, but we need a couple of clinicians at least involved. So we're reorganizing our services, my part of London, around open dialogue. What we're doing there is having hubs. So each team is based in a hub where you have 3 or 4 clinicians. Each of those clinicians will work with each patient. So that way, they will have a community of people around them that are consistent. So even when somebody's away or off sick or on leave, they still have folks who they know. They don't have to see different people. So that kind of heavy lifting to organize care that way is the operational bit, and then there's the other bit, the treatment bit. So it requires all of these happening to make it happen. And our trial, therefore, involves working not just with clinicians, but with managers and with leaders and chief executives in different parts of the country to make this happen. And we've set up trial teams in sort of 6 parts of the country, and really deep inner London, Camden, which is absolutely right in the centre of inner London. We've got Haringey, which is a little bit further out, but still fairly inner London. Waltham Forest, which is also pretty much inner London area. Then we've got Havering, where I work, which is outer London. Then we've got Kent, which is a bit more rural, not urban. Then we've got Devon, which is even more rural still. So we've got sort of a range of geographies that are pretty diverse. And we have trial teams in each of those areas, pilot teams. We started running it in 2017 when we did a little bit of pilot in my team in Havering and one team in Kent to demonstrate that it could actually be delivered in the National Health Service in the UK. But we were able to have patients come into the service. We were able to then do some measurements, just so look at some of the outcome measures and see some differences. So we did that pilot around 2017. We then got the full grant, which was £2.4 million at the time, in order to evaluate all of these teams. It's a cluster randomized trial, meaning that you can't randomize people at the point at which they're referred into our service. But what we do is we randomize that beforehand by geography. So certain geographies have been randomly allocated to open dialogue. Other geographies are randomly allocated to the control arm. And we're following those subjects up from both those clusters in each site over a couple of years. So we see the difference in outcomes for those. And the outcomes we're looking at is things like time to relapse. So does it take longer to return to service if you've had open dialogue compared to treatment as usual? You need less care in the long term compared to treatment as usual. And then we look at other things like functioning. Is your ability to work or study enhanced by having open dialogue? And then other things like social network and what that's like. We're looking at mediating factors and like I say, level of functioning, and as well as symptoms and standard outcome measures. So there's a range of things really that we look at as part of it. We also look at things like hospitalization, how many hospital bed days are you using, medication, how much medication you use, the whole battery of things. As I say, we started the main trial from around 2018, 2019. We had to halt recruitment in 2020 because of the pandemic for a little bit of time. Then we were able to restart. And the teams are so enthusiastic and excited about restarting. We managed to get them going straight away, which was very inspiring to see. We've now finished recruiting all the subjects that we needed to, which is a total of 500. So that makes it quite a large trial. And we're in the follow-up phase of a couple of years now. So hopefully by the end of next year, we should have finished. And we should then be sort of crunching the data and getting ready for publications. that's kind of where we are. We fought through a pandemic and all sorts of issues. There's been lots of diplomacy in terms of organising the services as well as delivering the training to staff on the ground to really change the culture and way of working. All of that. Plus, as I say, fighting through this pandemic, having to pause and then restart and continue, get some extra funding. We've now got 2.9 billion in total to finish the whole study and keep the research team going the whole way through. It's a collaboration of several universities, University College London, Middlesex University, King's College London, Birmingham University, so a range of them coming together with the evaluation, some senior academics across the country. So it's pretty mammoth task. But there's eyes of the world around us. Really, we've got folks all around. I was just giving a talk in Australia yesterday morning. Folks very interested in it and hoping that if we do produce anything like a fraction of the outcomes that they found in northern Finland, then it will be a game changer. So we're waiting to see.
Absolutely. And so I don't really know the geography of the UK. And so will your study have sufficient power to detect particular differences for minority communities, for example?
Right, good question. So because we've been fairly diverse in terms of the geography we've used. So we've gone right into inner London where there's a very large diversity of population there. And then we come out to more rural areas, which isn't so diverse. But we've actually got good teams now in very diverse areas that have a large ethnic minority population. So we're able to see that. We're doing an additional study. It's a bit like a large study like this is a bit like a whale where you have lots of small fish all around it. We've got all these small PhD projects and other studies around it, one of which is the actual impact on minority communities. Because where it originated in northern Finland, there weren't much by way of minority communities. So there's a lot more here where we're doing it. And we've found that there's some really interesting stuff in terms of tapping into some original wisdom within the community, aligning it with that, making it, making people understand it in that context. So there's some really interesting stuff coming about as a result of that. We're finding that by doing that, it really enables it to take hold in those communities and make sense. But there's work to do on the clinician's part to really become a part of that community, understand it, really liaise with them, and start to become partners with them. And over time, you start to understand their language and their way of doing it, and start to put that into the hot seat, if you like, into the driving seat to make the change. So that's what we're finding. But it's a very interesting question. It is as a subject of study as a key part of some of the work we're doing at the moment.
Related to that, have some insights from those minority, marginalized communities influenced the practice of open dialogue in your experience?
Yeah, I mean, it's beginning to, because we sort of started, and I think that we're hearing some great feedback from colleagues who work in that part of the world, and also colleagues who are from those communities. So we have a number of colleagues from those communities working in those communities, and they're feeding back to us in terms of, this is the way that it really is understood and it really makes sense. And so we're kind of organizing on that basis. Yeah, it's really inspiring to see that. But it's very much early days with that. So we're sort of writing up some of this and helping that understanding. And I see that as a very rich area of a lot of research in terms of understandings that we're developing and ways of describing and adapting open dialogue to these different communities. So that's just very much at the beginning of that journey. But I think it's going to be a fascinating one.
Yeah, certainly I would think that idea of improved sense of agency and control would be particularly powerful for those who have been affected by power systems. So I would think so, yeah. So moving from theory and the big picture aspects of this to bring it into the clinical practice, can you talk about the roles of presence, therapeutic relational attunement, mindfulness, and compassion in open dialogue facilitation?
Yeah, sure. So, the first thing we do in our training, a key thing that we do in our training is really help people open up to themselves. So this is fundamental. I mean, I'm a big believer that self-compassion is the root of all compassion. So we have to start with that, and we really start with that in the training. So we pair people up within their teams to work with colleagues, looking at their own genograms, looking at patterns that have traveled through their own families, writing reflective essays about things that happen in their own families and in their own lives. Starting to reconnect to that at a deeper level is really important. It really helps to kind of bring about that sort of deeper connection and understanding, and then and also to look into why they came into this field in the first place, right? What brought you here? What were the things that drove you to work in this area? And again, doing group work around that. And so what we find is that people often sort of reconnect in quite a visceral way to that compassionate side of themselves, which often through years of working in a system that's very mechanized has been kind of burnt out. So this is why the training is very immersive. So they spend 4 weeks together, not in a row, but sort of 4 1-week blocks up in the University of Cambridge, where we partner with to deliver the training. And they're beautiful surroundings, and it really helps them to sort of come out of the daily grind and really think about what brought them here and connecting more deeply to themselves. And that then I think is sort of like the soil in which the compassion emerges. That really intensive period of working on yourself. And so much of our training is actually that. And then from that, as I say, they go back to their work, they're reconnected to a lot of their compassion, and they can start to work on that basis. But yeah, most of my focus and most of our trainers' focus is on doing that self-compassion work for them, and the rest sort of follows fairly automatically as a result. But that does require a lot of effort because people aren't used to spending time with themselves. I mean, I often say that in the UK, I don't know what it's like in the US, but in the UK, psychotherapists have their own therapy. They'll have weekly or even more therapy of their own to help them do their work. Psychiatrists, psychiatric nurses, OT, social workers, they don't have any of this, right? And yet we are seeing people in far higher levels of distress and dealing with a lot more emotional complexity and difficulty, and yet we're not having any work on ourselves. So this is very wrong. So what we try to do is we try to set a new kind of paradigm where that looking after yourself is really key. We then ask them to continue this in their team meetings, where they practice mindfulness at the beginning of each team meeting, and they once a month they come together and sort of an away day to do some self-work together like this. And we do retribalizations and things like that, exercises together when we come together as a community, forge really tight links. And that's one of the reasons why I think people's affinity to their teams is so much stronger. We really have people who are connecting deeply to their teams and stay in their jobs for a lot longer. But I think all of that is really key. And I think it all really helps. So that, as I say, that self-compassion is where it really starts from, and it helps other things to grow up as a result of that.
Wonderful. So this is a healing process for practitioners as well. So that's so powerful. So let's say a young person is experiencing a psychotic break in the community. What happens next when open dialogue is integrated into community care?
Yeah, so I guess the first thing we do is that whoever calls us, whether it's that person themselves or other people related to them, ask them who else is important, right? Who are the other important people in your life? Friends, family, neighbors, anybody you can think of, bring them together, and let's see who we can bring together, right? If it's nobody, that's also fine. We'll still work this way. But if you've got people, bring them on. Sometimes just that person on their own, and then we'll start to talk about other family members and friends and gradually bring them in. And sometimes we might virtually bring them in, just ask about what they'd be saying if they were here. So there's always a way of doing it. But we try to emphasize that family, that community connection early on, and ask them, what can we do? Who else can we bring in? So that's the first difference. The second difference is we then assemble a meeting with them. That's more of a community meeting together with them and the clinicians. And we start it off with very simply asking, what has led to this meeting today? What are the things that have led to this meeting? We don't guide it any further than that. We don't say, what's wrong with you? What happened? And can you tell us about your symptoms? Or nothing like that. We just ask them, what's led to this meeting today? Give it an open, what's the history of this meeting? Give it just an open question like that. If we already know them and it's not the first time, we might just say, how would you like to use the time? And after that, we really try to facilitate that dialogue. So the clinicians aren't imposing themselves, they're not leading the meeting, they're not telling people that, okay, now I need to know this from you, I need to learn this, I need to learn this, can you tell me this, can you tell me? We're not doing any of that. We've actually taught them to enable that person to say more, enable that person to talk to the others there. So we're all trying to use some skills to hear voices, hear all the different perspectives out there. The clinicians are constantly curious, constantly asking people to say more, repeating some of their last words and encouraging them to come out more, asking them circular questions. What do you feel about what so-and-so said? Getting them to talk to each other, getting that dialogue, that richness, that diversity going, and also the clinicians, the clinical team reflecting to each other in front of the network. This is how it feels to me, not sort of interpreting or labeling or forming conclusions, but just empathizing with, when I heard them say that, that's how it felt for me. I can really understand this person's position and trying to connect to it wherever possible. We want to reflect on what we've heard, what we felt, and what we've connected to. So that's that, and then we carry on with the meeting. So we're all the time we're trying to emphasize that dialogue between them and that kind of their voice being the key ones that are heard rather than ours all the way through. So I guess that's a very different way. Often it's the clinician's voice, the doctor and nurse's voice that is the most powerful one in the room. We want to really change that. And at the end, we want them to have a say in terms of what happens next. Would you like to begin? What would you like to do next? You tell us. So yeah, very much a resetting. It's a bringing together and it's a resetting of the sort of dynamic, and that itself becomes very therapeutic. So I was giving a talk to some colleagues, some psychiatrists in London earlier today, and they were talking about the revolutionary nature of it being the fact that we realize that it's us and our interactions that can make the difference. It's the way we talk, how we help them talk, that can help to promote the recovery rather than just the medication itself. Right? So many of our services just focus on the medication. The response is medication only. Here we're saying actually it's these meetings, these dialogues that can really lead to the recovery. You can involve medication if needed, and if they really want it and they feel that there's things are too overwhelming, that's fine. But there's also that relational aspect which we feel can make the big difference. And so that's I guess that's the core in terms of how things might be experienced differently to treatment as usual.
Well, thank you, but this is really profound. But I'm also thinking of the challenges that you could encounter. For example, so many mental illnesses are worsened or aggravated by adverse childhood experiences. So very often, the person who comes in with the identified problem is not necessarily, there are other people in their lives who may have caused or been part of adverse childhood experiences. So do you encounter that? How do you deal with that situation?
Sure. So the first thing is that it's the patient themselves that has the first choice. They have the choice on who comes. So they always determine it. And if we feel like they don't have the capacity to make that choice, then we won't necessarily invite people without really knowing this. So the person involved has to make the choice. Also, where there's risk, we always follow the procedures we do at the moment. So in the UK, we have safeguarding, we have notifications and rules around how we interact with people. We'd follow all of that, right? And if there's need to separate people, all of that we'll do based on any risk assessment that we have. That will not be any different to how we do it in standard treatment. But it's very much the patient's choice. They will decide. The person using the service, the person's central concern is the one who really decides who comes and who doesn't come to meetings. And sometimes I've worked with people for years, with the individual, until they felt comfortable enough to invite one other person, might be sister or daughter or something, and that's been fine too. So we're very much guided by them. So that really helps. And we're very much alert to all of the risk processes we have, which we still continue as usual.
Oh, great. Thank you. So in your book, you also write about how there is often a quote unquote, shall we say it moment that comes up through the dialogical process. What is that shall we say it moment, and how have you seen those moments unfold?
Sure. So, what we're trying to do at the beginning is creating a safe space where people can speak their mind and their different ideas, different feelings and where they are. And it takes a bit of time for people to feel like, actually, this is my space. And this is something that it's not for the clinicians to dominate, it's for me. And they will sometimes have conversations before the meeting about what they'll raise in it. And sometimes those conversations take the form of, they might even have that conversation in the room. And they'll sometimes say, shall we say it? And what they're usually referring to is there is a trauma, there's some events in their past, in one or more persons' past, has really fed into this. And they'll start to come up with it, usually about 2 or 3 meetings in, and they'll start to broach those traumas and those underlying factors. And there's so much healing to be had through that process. It's really fundamental that we honor it, we're able to be present with it, we're able to allow people to speak their experience, and we don't say, well, let's get an expert, somebody else, so leave it there, we'll get a psychologist. So, we want them to actually be able to open this up. We're not pushing them, of course, but requiring them to. If they don't want to talk about it, fine. But, we allow them to do it. And that's often the beginning of some really major unpacking, some really major deeper level understanding of what's really going on here and what led us to this. And that's when they're starting to build their narrative. They see that event there has kind of, been a bit of a major cause of a lot of this. So they're starting to piece that picture together, which itself, is fundamental to recovery, to just understand how this all fits together, rather than ending at just a label, right? Going deeper than that and having a deeper understanding. So yeah, that shall we talk about it moment is very much when you can feel that starting. They're going deeper now. They're really talking about what brought them here, and that's when I think you can see some real shifts happening.
So you mentioned trauma, and this sounds like a very safe, supportive environment for someone to unpack and work through their trauma and work through the shame and stigma and all the difficult emotions. Uh, are survivors of trauma also part of this study, complex PTSD, etc.?
Yeah, and what we found, and there's really good evidence these days about the fact that there's actually very large amounts of people in our services with whichever diagnosis, whether it's psychosis, there's a diagnosis of schizophrenia or depression or mania, bipolar. There's a large percentage, majority of each of those groups of people have trauma in their lives. So for the majority of people, that's a major part of why they're here in the first place. So part of their healing is very much about understanding that, coming to terms with that, building a narrative around that, and that's what open dialogue really helps people to do. And of course, PTSD, where you have that's of course in there as well. But that sort of touching that trauma, understanding it, understanding how it has played a major role, is really fundamental. So yeah, across the board for everybody we see, that becomes a part of it. For some people, it may not be as much. For some people, it will be more, and other people will be less. But actually having the space where, if it's there, it can be brought up is, I think, really important. It's one of the things that makes a big difference.
So are you also actually training the identified patients and family members in mindfulness and self-compassion as you also work with open dialogue?
Yeah, so open dialogue itself kind of formally doesn't necessarily include that. In that what we're trying to do, we're trying to create a space, and we don't want to govern the space in terms of how it's used. We want it to be up to people. But they might say to us, I'm really interested in this mindfulness. Do you know anything about that? And in which case, then we say to people, then talk to them about your experience. And we say to folks, often a lot of our clinical staff haven't had experience of mindfulness before. So we'll say, tell them that. You tell them that, I've started learning, I've done a bit of practice. This is what I do. Share that with them as a peer, rather than as a kind of trainer and expert. Few people are actually trainers in it. So that then helps people kind of learn. And I've been in a number of network meetings where actually the families have been really keen to start with a meditation at the beginning of the meeting, a few minutes, which we tend to do. And that's been relatively common experience, actually. So we're guided by them. If they want that kind of work, they mention it, then we're happy to share our experience with them. That goes the same with every form of intervention that we bring into open dialogue. I describe it a bit like a carpet. You can put all sorts of things on top of it. So whether it's medication or hospitalization or other things, or some self-compassion work, some forms of therapy, some meditation work, all of that you can put onto that open dialogue space. So that's very much how we do it, and we do quite often actually end up doing those things, but very much at their behest.
Wonderful. So it's kind of it's more in the water than actually formally prescribed. So that's great. So for those who may be interested, can you briefly touch on what open dialogue training looks like? If clinicians are interested in exploring this model, what resources are available?
Sure. So the open dialogue training, the original training in Finland was a 3-year training that they did, and I worked with them for a couple of years to develop a bit more of a bite-sized deliverable training for frontline clinicians. Not everyone could go on a 3-year degree. So we organized it into a 1-year training, so 4 1-week blocks across the year, where people fairly immersively come together with their teams. We try to train teams together rather than individuals, because this is about how a whole team works together rather than individual. But we still do have individuals come. We actually have individuals fly in from around the world. So we've had folks from as far afield as Israel in the east, and the States in the west, and parts of Europe come fly into the training. This is a residential training, so people can come and stay. It's fairly expensive. It's a few £1,000 because of that, because it involves full board residential for 4 weeks across the year as part of that training. But yeah, it's those 4 residential weeks. We then ask them to go back to their own services, start to use some of these methodologies, and start to reflect that in reflective posts. We have like an online system where people are reflecting things to each other, sharing it with each other, learning from each other, and also doing some of that self-work, reflecting on their mindfulness experience and other things with each other as well. So that's kind of it in a nutshell. It goes from across an academic year, from September to June, based up at University of Cambridge, where it happens. And there are other trainings around the world. There are trainings in the States. Mary Olson, for example, runs a training out of Yale in the States on the East Coast, and she's also very affiliated with our training. She comes and delivers training in our training as well. And we also deliver a little bit of training on her side too. So, we work very closely. And I know that there are other trainings developing, and there are trainings around the world now. So it's quite very much a growth area. We get sort of inquiries from all over the world about the trainings these days. And there's one time for several years, we trained whole teams from a different country, from the Netherlands. We had about 80 or 90 people from the Netherlands come year after year, and it really helped to transform a lot of the landscape at that time over there. So it's quite a journey, and it's very much a personal development journey. It's a personal journey. People go on a lot of their own, a journey into themselves through that training, as well as about learning a professional skill. I also run retreats for psychiatrists once a year, mindfulness retreats. I often ask them at the beginning, why are you here? And we sometimes ask that in our main open dialogue training. And people often say, well, it's for myself, to work on myself in the mindfulness retreats, or they'll say it's for my patients, to help my patients. And I usually say, well, the great thing about this training is you get both, right? This is for both things. And same with the open dialogue training, it's actually for both of us, that to be able to work on ourselves as well as to be able to help our patients. Those two things are pretty much inextricably linked. Our trainings and our backgrounds don't often think about it this way, but we really see it as any training has to be training for yourself to heal and recover and improve and grow in yourself, as well as for your patients. That's the only way you'll really benefit. That's sort of a broad idea really of my training.
Well, Dr. Razzaque, this just makes so much sense. I wish this could have been integrated into my training and integrated into the training of so many others. But what are your aspirations and vision for how the open dialogue model can be more widely adopted? Where would you like to see this end up?
Yeah, well, I guess that our study at the moment is kind of my biggest focus, and we hope that if we get a fraction of the outcomes that they had in Finland when they did their original evaluations, it will be a game changer. And we really want it to be able to affect policy around the world, but also in a kind of collaborating a scheme with called Hope and Dialogue, which the Italians developed, which is all about, our trial is called ADESI. It's a complicated acronym. Academics love the acronyms. And we're basically helping to develop studies around the world that are small copies of ADESI, small scale versions, don't have to be randomized, don't have to be so large, but small scale versions using a similar data set so that we can build the evidence base and it can help to create a more powerful argument. And we can say that it's not just in the UK it works, it actually works in various countries around the world. So we're working with international colleagues to help to also deliver similar results in smaller studies around the world. So we can say that actually this has really got legs, it can work across the board, transdiagnostically as well as internationally. I hope that when we do that, then it can really get onto international sort of recommendations and policy guidelines, and we get policymakers really involved in that. So that ultimately, this can be a major plank of policy development around the world in terms of how we deliver mental health systems. So I very much hope in the UK it becomes a part of our standard treatment eventually, and that also helps that same process happen in other parts of the world too. That's my dream. I do believe we can get there, and I think we're headed in that direction. But there's lots of ups and downs on the way, but that's the direction of travel I very much hope.
Well, thank you for all of this and for reminding us that we're still understanding and you're doing the scientific research, and that can be very slow paced. And I also like to say change happens at the pace of relationship. And with relationship, all the understandings that come with relationship. So it's a slow process. Relationship is a slow process. So thank you again for all your work, and I appreciate that. Anything else you would like to finish up with?
No, that's all. I mean, it's great to talk to you and to talk to colleagues around the world. I just in the last couple of days, I've spoke to colleagues in 3 or 4 different countries, and it's just wonderful to see the interest that there is out there for this. And I believe that. While we have to go through all the steps, I think that momentum that's building is really something that's happening in society more widely with all the things we see around us right now. There's this yearning for reconnecting in communities and using those ways of governing ourselves, of healing ourselves. But it's an exciting time, and it's great to see people across the world who are interested in it. So thanks very much for inviting me, and it's been lovely to speak.
Thank you. It's been an absolute pleasure.